Welcome to episode 139, everybody. So excited to see you. We're going to be talking about regionalizing crisis care in Central Maryland today with two amazing speakers who are here right in front of Annapolis, Maryland. They shared with me that that's beautiful Annapolis, Maryland. And I know a lot of you are from Maryland on this call. And so we're really going to be hearing about them as an incredible template for work that a lot of us are doing around the country. So looking forward to that. Remember always to visit us at Crisis Talk. You can find the Zoom link if you're kind of panicking and you're on vacation. You're like, I want to join. Don't worry. Just go straight to the website. You can join the Zoom link right there. No problem. You can also see what's coming up. And if you missed something, for example, if you missed last week's, I'm telling you, it's a YouTube to visit. That was the one of Day in the Life. And we talked about teen crisis lines. We had our first ever 20-year-old host. And if you weren't there, I'll tell you, it was really inspiring to hear from these guys. And so it's one to revisit if you didn't get a chance to see it. And as you know, if it disappeared and you're like, it's Wednesday, why isn't that on my calendar? Don't worry, you can get it back. Go to the Crisis Jam sheet and you can re-download the calendar invite, no problem. As you know, you can visit any of our previous talks on YouTube. We've got an immense amount of people who are watching us live, but even more who are joining us later on YouTube. Our youth special edition is still one of our top ones, but look at all these other great ones that we've had. Tech edition, when we went live at receiving centers, just so many good topics in there. So if you joined us later in the life of the jam, I really recommend going back to a few of the old ones. Now, if you were here on our 100th episode, our 1-year birthday, when we had the big cake, we did our first over-under, and we're going to do another one today, and I'm going to bring forward Rin to help us with our over-under. So those of you who know what over-under means, we're going to ask Rin a question. She's going to give us a cut line. And then you're going to guess if the actual answer is higher or lower than her guess. And I know her, she's going to make it hard on us. So here's the question. What percentage of the world's population will experience a mental health disorder? So this is lifetime prevalence, okay? And this was in something that came out recently. You can see in the upper left, a crisis news thing. So Rin, what do you think? Lifetime experience a mental health disorder. What you think?
I know it's higher than I think people would guess.
Yeah,
but I'm
right.
not entirely sure what that number is. Sometimes I think all of us, but
yeah.
A diagnosed mental disorder, maybe. I don't even know.
We'll just make a guess. So we're talking during your lifetime, your whole lifetime, any disorder. Okay. And obviously don't guess 99 because then everybody will get it right. But give us your best guess. What do you think?
I'm going to say 30%.
Okay. 30%. So 30, not 3, 30%. So those of you, we're going to have a little thing come up, I believe. Is it higher than 30% lifetime prevalence or lower? So guess over if you think it's 31% or higher. If you think it's 29% or lower, do under. And we'll put it submit, and let's see what we get. Let's see what our audience says. 88% believe it's over. And you know what? That was your first gut, right? That it was a really high number. So let's see what the actual number was in the article. 50%, 1 out of every 2 people across the world are going to experience a mental health disorder. So that means it's either going to be us or someone we love, probably. So we really, it's all of us. It's not an other thing. It's all of us. And so really appreciate you coming forward today. Love seeing your face and talking about this population. All right. So a few other little news pieces this week. One news piece here in Maryland Matters about 911 call centers, really focused on the stress on those who work at these centers, right? A lot about how that feels and how that's challenging for folks. I actually wrote down the quote from the article. Let me see if I can pull it up. The job of a 911 specialist is oftentimes extraordinarily stressful, said a retired 911 call specialist, Sue Greentree, in Anne Arundel County. So I think a lot of us can resonate with that. Now, if you've been watching the news lately, you see our Simone Biles is back at gymnastics. But if you remember, a couple of years ago, she took a break for mental health, and everybody was kind of up in arms. But she said, "I need to take a break for my mental health." And it's great. She's coming back with a vengeance. So we're all really excited to see her back and healthy. Lastly, I'll just say that there was an article in the New York Times, and this has been a lot of talk around social media. And for one group of teenagers, they saw social media seems to have a clear net benefit. So the quote from there was, despite the Surgeon General's warning about its risks for youth in general, researchers and teenagers say it can be a lifeline for LGBTQ youth. And if we remember from last week, a lot of them said that they have found a lot of support in social media and on warm lines. The teens said that last week. So just to let us remember, there's two sides to some of these things. All right. The SAMHSA store. I love it. I go shopping there all the time. There's posters, there's magnets, there's all kinds of great stuff there that you can order for yourself, for your clinic, for your clients, things to remember, to keep 988 right at the forefront of where you work. And remember, Spanish options. T-shirts. You guys, I have such great news about T-shirts this week. I'm wearing mine, but I heard from David Covington before we started today that he's coming out with some new versions. There's going to be one that's going to be a little bit different material for running, maybe some non-sleeve ones for running. And also, David told me he was really inspired by last week's group, and he's looking for some different designs, maybe more of a graffiti anime, I don't know, but something good's going to come out of that brain of David Covington's, and we're going to see it on a T-shirt. So, I know you're thinking about, what are we going to wear in our family holiday card this year? What are we going to all wear denim? No, let's all wear different 988 shirts for your family holiday card this year. That would be really fun. All right. All right. Well, bringing up one of my favorite people, Matthew Goldman, who is going to join us today. There's so many titles that he has. He was a SAMHSA policy fellow. He's actually, Matthew, I don't know if you know this, but you're actually tied for the most Crisis Jam feature presentations. Can you believe that? You're like tied with that. And also, I know that you just recently took on a big new job and moved across the country. Tell us about that.
Thanks, Amy. Not quite across the country, just up the coast. I was in San Francisco, and so now I'm in Seattle. It's very exciting. I'm in a new role with King County, which is the large county that surrounds the Seattle area. It includes Seattle. An initiative was passed just in April by the voters of King County to fund 5 crisis care centers across the county, 4 for adults and 1 for youth. This is a major investment of $1.25 billion over 9 years to significantly expand the crisis center physical infrastructure. So it's very exciting what's happening here in King County, and I'm the medical director for the implementation planning of this process.
Well,
so excited to participate in that, although I'm not sure I know anything about what this question's about to be.
Oh, well, don't worry. We've got help. And I will just say, I saw your announcement on LinkedIn, and so many people I noticed commented how excited they were to have you in Washington. So what a gift to have you there. So let's go to our question. 2 years ago, Crisis Talk interviewed Tequila Terry with the Maryland Health Services Cost Review Commission on the state's investment in behavioral health and crisis services as part of a broader initiative and agreement with CMS called the Total Cost of Care Model. Okay, that sounds like a kind of model that you would know about given your data bent. Okay, so which of the following targets did the agreement between CMS and Maryland highlight for the end of 2023? What was their kind of one that they were really going to highlight? Was it 20% increased timely follow-up after acute care? 30% decrease in preventable hospital admits, 50% decrease incidence of overdose deaths, or 1 billion in Medicare savings. Now, the audience, as you know, is extremely bright on this, but this is a hard question. So I'm going to ask you if you feel like you want to phone a friend, you feel like you want to kind of talk it through. What are you thinking?
Well, I'd love anything in the chat that folks from the audience are thinking.
Okay.
It's a great question what Maryland has done. I have learned a little bit about, and it's definitely a national leader in really, innovative cost models for acute care services. The total cost of care model, I thought, had mostly to do with hospitals. So all 4 of these goals are super, super important, but I might be leaning a little towards either preventable hospital admits or maybe the Medicare savings, although that is not so much about Maryland's Medicaid plan, which I think is what this had to do with more.
Okay. Should we see what the
I'm just
audience had to say?
What's that?
Should we see what the audience had to say?
Yeah, let's see what the audience thinks.
Let's see what the audience says. You're leaning
matches
towards
me.
B or D, it looks like. Ooh.
I'm leaning towards B or D.
Oh.
The audience has B. I was kind of leaning towards B because of the hospital focus, from my understanding, in Maryland. So, hey, I'm willing to give it a shot. Let's go with the audience and my inkling and see if B's the right.
Final answer, B. What's the answer?
Uh-oh, David says phone a friend, so I'm sure that's the wrong answer.
That's never a good sign. So should we ask Paul Galdish to come forward?
David told me I should ask
us.
Paul.
Help us.
Paul, I'm putting you on the hook now.
Oh, Paul, nice shirt. We match. I love it. So Paul, do you know anything about this? I'm kind of feeling, since David said to call a friend, that maybe B is not right. So do you feel strongly about any of the other 3 answers?
Well, it's interesting because, Matt, you thought through that well. I think Maryland is focusing on preventable hospitalizations, is true. So I think you've leaned into that the right way. And of course, we know that eventually we want to impact total cost of care savings. But early on, I think you're looking at the right sort of options. I do think A, B, and C all have their merits. But if I were answering that, I know David said to phone me, but I think you're leaning into what I would have answered as well, which is B, decreasing these preventable hospital admissions.
All right, we're going to go with B. We have to go with our gut. Let's go with B.
We can all be wrong together. That's okay.
That's
right, Matt. We're in this together.
Right. D. But actually, Matt, that was your second gut. So I'm going to give you a half point on that one. So it turns out that actually all of these were goals in this, but they decided to really focus on the one that's the 1 billion savings, but all of these. So basically you were right. The first 3 years, 19 to 21 of the TCOC model showed success with decreases in hospital spending that were greater than increases in non-hospital spending. But these savings were lessened by substantial increases in the latter of 2021. But we don't know what the answer is yet, because the answer is through the end of 2023, but the goal is the 1 billion in Medicare savings. So, I mean, here's my feeling. I think David should give you a shirt. I mean, it's just me, but anyways, but thanks for coming forward, and we're going to hear from you later in the data corner. So I'm looking forward to that. Good to see you today, Matt.
Thanks for having me.
All right. All right. So a quote from Tequila Terry, who we were just talking about. We knew that if we wanted to address overdose mortality and high utilization in hospitals, then we had to look at the role of behavioral health. And I think that quote resonates with a lot of us. First said in July of 2021, but still relevant today. All right. So I'm so excited to turn it over to our speakers today from Behavioral Health System Baltimore. So we'll bring forward Adrienne Breidenstine and Chauna Brocht, and they can introduce themselves. So happy to have the both of you here today. Looking forward to your talk.
Thank you. Good afternoon, everybody. I'm Adrienne Breidenstine. I'm the Vice President of Policy and Communications at Behavioral Health System Baltimore, and I'm going to have Chauna introduce herself next.
Hi, everyone. Thanks for having us today. My name is Chauna Brocht. I'm Director of Crisis Services at Behavioral Health System Baltimore.
Great. So we're thrilled to be with you at the Jam for the second time. You may, hopefully some of us may look familiar to you. We were here about 2 years ago when we were talking about, hey, we're going to regionalize crisis services in Central Maryland. Well, we're here to give you an update, and I'm happy to say we did it. Not without a lot of work and milestones to be achieved, but we did it. We're here, and we're going to give you an update on how we got here and how things are going. As a quick reminder for those who know us or those who don't know us, Behavioral Health System Baltimore is a nonprofit organization, and we serve as the local behavioral health authority for Baltimore City. Next slide. So what that means is we are at that systems level. We are not a direct service provider. We have a role with advocacy and planning for our public behavioral health system. We manage around $60 to $70 million in funds annually for services that are not reimbursable through Medicaid. We also work very proactively to develop local partnerships with other system partners like law enforcement or foster care to ensure that our systems are connecting and coordinating. We do a lot of public education, a ton over the past year or so around 988. And then finally, we have that system management role where we oversee the full range of services within Baltimore City. Next slide, please. So in terms of crisis services, we've had a role in overseeing our crisis system for quite a long time in Baltimore City, and now we're doing it at an even broader scale. Our role is around accountability, funding and accountability. So as the local behavioral health authority, we've administered grant funding for crisis services. In Maryland, our crisis services have primarily been grant funded for decades. That is about to change, thank goodness. But we have been the one administering those grant funds in Maryland or in the Baltimore area for the past several decades. We work in partnership with the state to oversee services that are grant funded, but also reimbursable through insurance. We investigate complaints and sentinel events, and then finally partner with our stakeholders. We have a variety of crisis providers across the state, and now we have a variety of providers serving the Central Maryland region. Our LBHA structure does vary across the state. We are very fortunate in Baltimore City and in Central Maryland to operate in this nonprofit structure. It allows us a lot more flexibility with how we can administer funds, but then also how we can operate and move throughout both in the political and system environment. Several years ago, around the same time when we had recognized the benefits of regionalizing, our state also laid forward a vision for regionalizing crisis services across the state. And Maryland really wanted to work, the state of Maryland wanted to work with us as a test case to see how we could go about regionalizing services. So that is what we've been doing for the past 2 years. Next slide, please. So just wanted to walk you through what we see as, some of the milestones. The catalyst for us here to really help regionalize our crisis services is related to what Amy was just talking around, or Tequila Terry and the HSCRC. We applied for and got a grant from the HSCRC, which is the state level entity that regulates our hospitals in Maryland. And the grant was to expand and build out infrastructure for crisis services. This grant opportunity provided us the catalyst funding, but then also partnership opportunities to really regionalize. So we convened our stakeholders for the very first time, knowing this grant opportunity was coming back in the summer of 2019. We started with our Baltimore City hospitals, but then in talking with them, quickly realized many of our Baltimore City hospitals also had hospitals in other areas of the state, in particular around Central Maryland. As conversations evolved, we realized that it would generate more funding, but then also serve people who are in crisis better if we did apply as a regional entity. So we did that. Our grant was awarded in 2020, and we started the project in 2021. It may sound familiar to you, it's called the GBRICS project. We have recently rebranded and repositioned this project as the Central Maryland Crisis Response System, and that's because we are operating on a regional basis. And you'll hear a bit more about that from Chauna in a second. Our first year of this work was a heavy planning year. We spent a lot of time working with stakeholders, not just crisis providers and our hospital providers, but community groups in developing crisis system standards, in working around community engagement to bring people in, and then finally around doing a lot of community engagement and market research in anticipation of 988 launching the next year. What this led to was, at the end of the first year, was us having crisis standards that are available on our website, but we used these standards to operationalize and regionalize. They ended up going in RFPs. They ended up going in contracts. And they really helped to elevate the expectation with our providers, but then also within the community of what type of service they would get if they were to call 988 or have a mobile response team come out and respond to them into the community. We started implementation in 2022, of December 2022. So with this year and a half of working through some of this community engagement, there was a lot of things at play. Anytime you're regionalizing, I don't know about other areas of the country, but in Maryland, it's probably no different. Every jurisdiction has their own flavor. Every jurisdiction has their own unique politics and leader of that jurisdiction. So managing the politics, both regionally and then also at the state level, is something to take into consideration, and takes a lot of manpower and work and lots of conversations to keep everyone on the same page and keep you all going forward. So that leads to a lot of work doing change management. We tried to be very intentional about bringing people to the table, forecasting for them very clearly where we saw our system going. For example, that we did see our 988 helpline to begin to operate regionally instead of having 3 separate hotlines. So being very transparent and forward about that up front is one of the things that we did to help lead our change management. Our 988 rollout, what it meant at both the state and local level, we had to coordinate very intentionally with our state health department and behavioral health administration. Chauna can tell you, we have still have regular meetings with them, but coordinating up and so going up and out and down in terms of that change management was something that was really important. The other thing that is very important for us, and we were regionalizing, is least police response possible. As we looked at this as a goal of our regionalization, it's something, again, that we were very intentional about and very forward about. So our partners knew this is the direction we were going, but there was a lot of politics behind that, and still is, and a lot of fear. A lot of people in our regional partnerships still have a lot of fear about not having police respond when they're having mobile response teams come out. So balancing all that and looking at the unique needs of every jurisdiction are just some of the things that we had to look at as we regionalize. But within all of that, there are a lot of opportunities. And the last thing I'll say, and we're also very intentional about this and continue to be, is ensuring that we had community meaningfully involved at every step of the way. So we involved community in the beginning, very beginning. If you remember that timeline I showed where we were talking about doing an application, we brought community members, people with lived experience, people who have called our helpline to the table from the very beginning and have kept them involved, even with the implementation of this. And Chauna will go into that in a little bit about how we have some very unique community partners involved in a really great way. That's really important, especially with change management, but also with long-term culture change, which I know we're all trying to achieve with building out our crisis response system, in that we want people to be using our crisis response system or using 988, for example, instead of calling 911 or going to the emergency department.
Great, thanks, Adrienne. Next, I'm going to talk a little bit about some of the investments we have in Central Maryland to support regionalization. So we are 2.5 years into a 5-year, $45 million initiative to invest in our regionalized services. So the region that we serve is around 2 million people. So that includes Baltimore City, which is surrounded by Baltimore County, and then Carroll County and Howard County to the west. So that includes a urban area, suburban areas, and some rural areas as well. So we have a lot of diversity in our region. The first thing we did was we stood up a regional 988 helpline And that is a partnership of 3 agencies that work together to answer 988. And they use a cloud-based phone system, so they're all in the same phone system. And they all use behavioral health link software for the care traffic control. So that really allows them to build a partnership together to work to answer 988 and to coordinate through care traffic control, the mobile, the outpatient appointments and inpatient appointments. So far we've answered over 1,500 calls per month. We just launched at the very end of April, and we're seeing that trend upwards as well. We've also invested in our mobile response teams. So our mobile response teams are a clinician and a peer model. So they're a civilian-based team. They are dispatched through Behavioral Health Link, the care traffic control. The new teams that we funded serve more than one jurisdiction. So we have one agency that provides services in all 4 jurisdictions, and the other that provides services in Baltimore City and Baltimore County. And they've both opened new offices that are more regionally placed to serve the entire region with faster response times. And as Adrienne mentioned, we want the least response possible. And so some of the jurisdictions only had a co-responder team, so this provides an alternative to that. We've also been investing in access to outpatient clinics through open access. And so we have right now 17 clinics that receive referrals from 988 calls through a secure portal using the BHL software. And they're able to offer same day or next day access to ongoing care for non-acute callers. So if someone's calling, they're not in an acute crisis, but they really just need to get connected to that ongoing care. They can do so through 988. And then we also are using bed registry software to better coordinate community-based inpatient referrals. Right now we have 2 facilities in Baltimore City, one serving mental health, and then and also substance use, and the other providing substance use services. So next slide. So we have also been doing marketing regionally, and as Adrienne mentioned, we invested a lot before the launch of 988 in both community engagement and marketing research, and really listened to the community about what their fears and concerns and opportunities were with 988. And what we found is that 988 embodies hope for people, that the word crisis was overwhelming, so we stay away from that word. That helpline was a better descriptor than hotline. And really that the biggest barrier to calling is that people don't know what to expect. And so the graphic below is one way that we try to communicate what people can expect when they call 988. And I believe our next slide is a video, a very short video as part of our marketing efforts.
Anyone can call 988. When they call, they will get the greeting, the message, and then after that, you'll get a kind person to pick up. Right off the bat, we want you to know that we're here to support you, we're here to help.
You're not talking to an automated system, you're talking to someone that can actively be with you in that moment.
You know, what in this moment do you need? Is it a friend to talk to? Is it just someone to sit with you in the chaos that's happening? Or is it, do you need services? Do you need a therapist? Do you need a psychiatrist? How can we get you those services right now?
I'm a big advocate for doing breathing exercises over the phone so that someone hears me. They know that I'm with you, I'm gonna laugh with you, I'm gonna joke with you.
By the end of the chat, I've gotten them to laugh. I've gotten them to be like, okay, I can figure out what to do from here.
People that watch this should know that there is somewhere they can go. There are people they can reach out to whenever they need. It's safe.
Thanks for showing that video. And I'll mention that our colors are continuation of colors from our previous local helpline. So that was a good way to show some continuity. The other thing that we're doing in terms of community engagement is our 988 ambassadors. And this is some of our ambassadors at our 988 ambassador appreciation. And so we have over 50 ambassadors who are leaders in their community that go out and spread the word in very creative ways. So they receive a stipend and the promotional materials, and then they can promote, whatever creative way that they can think of. So one of the ambassadors did a 988 scavenger hunt. We have another ambassador who is a DJ and does different community events. So they really use their creativity, and they're also local leaders. And so when we, I think this made the national news, there was a mass shooting in Baltimore recently, and that community is very distressful to outsiders, but we had an ambassador in that area who was able to promote 988. So that was really showed how we laid the groundwork for that. So lastly, I'll just go over some benefits of regionalization, which we think there are many. There's the consistency portion, and I think Adrienne mentioned the regional standards that we created that create a baseline and a foundation for our services in the region. We're also in the process of rolling out a 988 triage matrix, which was designed to determine what's the best fit in our region in terms of phone counseling or a civilian mobile response or a co-responder response. And that was developed by our local providers and a consulting firm called Dignity Best Practices. So that'll be coming out soon. I think the economies of scale are really important. We've been able to afford software that we wouldn't be able to afford, including workforce management software. And then doing that marketing and community engagement on a regional level has been a big benefit as well. We can cover low volume shifts that might not have a lot of volume, but they can cover multiple jurisdictions and make that worthwhile. And then also, speaking of coverage, it's not on my slides, but we recently had a weather event here where thousands of people lost power, including one of our providers. But because we had this regional approach, they were able to cover for each other. So that was really, really great. We have staffing specialization. So if there's a Spanish speaker in one region, Spanish speaking provider in one region and not another, we can send that provider. Accessing resources that were previously only available in Baltimore City, and now they can be available regionally. Best practice and expertise. It's really been great to see everybody share that with each other among the 3 agencies. And then building relationships for our advocacy efforts. So we are about to launch our Fund 988 campaign for a telecom fee for sustainability. And we also all got together to comment on proposed Medicaid regulations. So those relationships that we're building through services are really translating to advocacy as well. So I think that's my last slide, is a quote from one of our community engagement sessions, which is, this all sounds freaking amazing, but put it into action, made me believe it, show me what you can do. And that is what we're striving for in our region. So thanks for this opportunity today.
Thank you, Adrienne and Chauna. This idea of regionalizing is just amazing, what you've done to kind of shift that area of the state. Really amazing. And we're lucky today to have 3 experts to kind of reflect on their perspectives on the work that you guys have done. And so I'm really excited about that. So we'll bring forward first Dr. Belina Shaw from SAMHSA, CMHS. Hi, Belina. We have about 10 minutes for the 3 people on the round table. So I wanted you to kick it off, if you wouldn't mind.
Sounds good. Well, first, I just want to say congratulations to Adrienne and Chauna on all the work that you guys have been doing. I was able to see it grow from the beginning, and it's just so exciting to see the work, as I am also one of those other Maryland residents, and was able to work on the sister project in another county. I just love the video. I think the video just demystified 988, and when we think about the importance of 988 and marginalized communities, and just making sure that we know what it is and not just this sort of amorphous abyss of a line. So I just love the video. And also, I just also want to just say that it's so exciting to see barriers being broken down. I think that it's so easy to think that county lines, city lines are silos, and I know this is not unique to Maryland, but that it's quite a feat to think about breaking down those barriers. And I think it's a really important one. You can tell from the workforce work that was done, and just to be ability to share workforce initiatives and efforts. It's so important. And then finally, the advocacy. When you regionalize, you have the power to advocate, and especially being able to do that from the voices of many, especially when your state may not always know, the state cannot always know what the locals need, and also that the state may not be able to advocate just because of the political pressures and positions that people are in. So just being able to create a collective voice in this way is so important and so impactful in this time of transformation with 988.
Thank you so much, Melina. I'm going to ask Shannon Scully to come forward, Director of Justice Policy and Initiatives at NAMI. Shannon?
Yeah, and you know, the folks doing this work know how much of a fan that we are at NAMI of their work. We've had them on a number of speak at a number of our events, and so they're just doing really great work. But you know, I'd echo a lot of the things that Melina kind of said. You know, I think we've run into this over a number of years in our work to try to change crisis response for people with mental health conditions, that, you know, people don't just live in their city, they don't just live in their county. I mean, I am also a Maryland resident, and I could tell you that, you know, every weekend I go from Washington, D.C. to, you know, Hyattsville to, you know, Montgomery County. I mean, I'm in and out of a lot of different areas just kind of in my daily life. And so, you know, that expectation and that consistency that we can create through some of that regionalization, so that, you know, you as a person who might be in crisis, when you're calling, you don't have to think about, oh, did I cross over a boundary? Am I not going to be able to get that same service? And that consistency of service is going to be so important as we really try to help people, you know, really trust this system and really support it and really reach out and
I think Shannon's frozen, but not in a good way. So we'll pull forward and we can come back to Shannon for her last final words, but let's go to Carlos McCall next, strategy manager and behavioral health lead at Totally Linking Care in Maryland. Hey, Carlos.
Hey, Amy, how you doing? Thank you.
Good.
And thank you also, Adrienne and Sean. You all are doing a wonderful job. And, you know, I'm very thankful to be able to work alongside of you in some of these projects. And just really want to highlight all of the great things that you're doing in regards to being responsive to your community. You talked about that mass shooting. And I think what's really important is how you incorporated the community. You sought out an ambassador to actually be there and work with the community alongside of you guys and really strengthen that unified message of the importance of, you know, reaching out for help and utilizing 988. So all of the work that you're doing is great. And I'm really thankful for the way that you all are working through the state to make all of these services sustainable and kind of leading the charge for the rest of the state to follow. So thank you very much for that.
Carlos, thank you. Shannon, did you have any final words? Are you back? You want to say any final words? Okay, that's okay. No problem. I think we got the gist, and I think overall, just all really amazed at the regional work that you're doing. And I really resonated with the idea that Shannon said about how we travel back and forth over a lot of different counties and cities. All of us do, just the way that the world works these days. And to know that things will be consistent across those is really important in terms of feeling trust and safety in the system. So I'm happy to bring forward John Palmieri from SAMHSA. Hi, John.
Hey, Amy, good to see you. Thanks for having us today. I am going to use our time today to welcome the newest member of our 988 and Behavioral Health Crisis Coordinating Office. I'm really happy to report, I think we did report out on this a couple of weeks ago, but actually she's here today. And so we're going to have a couple of minutes to introduce herself, but wanted to welcome Jill Mays, who's our new Division Director for Crisis System Transformation in the 988 office. Of course, very much focused on the full crisis continuum, building on the momentum success with 988 implementation, and really appreciative of having her join the team with her expertise and experience in the state of Georgia. We have tons of, we're very grateful to the state of Georgia for bringing us so many gifts to the 988 office, but I'm going to hand it off to Jill to introduce herself to the group.
Good afternoon, everybody. As John said, I'm Jill Mays. I'm the new Division Director for Crisis System Transformation, and basically what that means is I will be working with all of you and others across the country in kind of building out and helping to evolve pillars 2 and 3 of the 988 continuum. And of course, that's someone to respond and a safe place for help. As John said, I come from the great state of Georgia and was really excited to hear everything that Maryland is doing in terms of regionalizing crisis care. And in Georgia, we've been in the game for years in terms of developing the crisis system. So looking forward to learning all the other wonderfully creative ways that you all are finding to serve those in your communities, those that you love and care about. And immediately, my past role at DBHDD, I was the director of the prevention office. So that included all of suicide prevention. And when I was the assistant director of adult mental health, kind of had oversight of crisis services. Also did a little time working with the disaster distress helpline when that first rolled out, was a regional director, so a lot of experience with call centers as well. And I'm looking forward to meeting lots of you and working with you, and I'm just confident that all of us together, I know we will make meaningful transformation because just on this call, this is one of the most exciting meetings I've been in all week. But I feel the passion, and I know that, you know, where there's passion and there is wisdom, there's no limit to what we can achieve together. So again, looking forward to meeting all of you and working with you. And thanks for welcoming me to the group.
Thank you so much, Jill. Welcome, welcome, welcome. We'll get you a 988 shirt so you can be part of the 988 t-shirt crew. But we're really excited. And as you know, we've had many amazing leaders come out of Georgia and join our community. And so happy that that you're here today and moving forward. So we're going to move on to the Nashville update. Arlene Stevenson, wanted to call her forward to give us the update. Hi, Arlene.
Hi, Amy. Good afternoon, everyone. I'm glad to be here with you. I want to tell you there's some surprising activity happening this summer. It's something that's not normal. It's legislation. Yeah, I know it's not exciting, but it is unusual. Most states are out of session this time of year, but a few have been active even in 95-degree temperatures. I'm not going to give any more details because I know the folks later in the hour will be giving you those details. But I did want to say that I hope you have as much hope as I have from the recent polls and talk that, you know, share the information, the data on 988. And that because of that, we know that more people are becoming familiar with 988. And as our marketing proliferates, I think the interest will grow in developing 988 and crisis systems and hopefully in funding them as well. In fall, the General Assemblies will begin and they create agendas for the coming sessions. So it's time for you to start working your magic with your legislators. You want to inform them about 988, or you can inform their staff, their friends, the companies that are in the districts, anybody who knows them and will listen. And in fact, a little tip is that your state government relations office staff already has bonded with the legislative staff. So they are excellent people to send out and to get them to put their foot through the door or in the door, maybe not through the door. Nashville also has a one-page FAQ that will assist you in discussions with the legislators, and it's something you can drop off in their offices too. I will attempt to put that in the chat. And if you're ready now to tackle legislation, you know, I don't want you to miss out. Nashville has a template that will assist you with writing a bill. You don't need to scratch your head and, you know, mess up your do. You can try developing the language yourself, or you could just simply edit the template. You can fit it to meet your state's needs, and you're looking at the template there on the screen. We have a 2022 version, but now we've updated it, and there is a 2023 version, the 988 model bill, and you can use all of it, or you can use only the relevant parts of it, whatever works for you. Just to give you a little information on the content, it begins with definitions. It describes the components of a crisis system. It designates the 988 life centers. It talks about the compositions of mobile crisis teams, emphasizes cultural and linguistic competence. It also emphasizes at-risk and special populations, children, and more. On the next slide, you'll see that there are some newer topics that we added in 2023 because we have an interest in behavioral health parity and equity. We suggest forming a committee to help coordinate development of response protocols for 988, 911, PSAPs, law enforcement, whoever your stakeholders are, and also has provisions for building some financial stability, which is so important to your system. We also put NASHB's new national guidelines for youth, young people, and families in the template as well. So I want you to get to work, get out there, spread the word in the next few months, start working on your legislation, and I'm looking forward to seeing your announcement about your new 988 law in just a few months. Thank you.
Arlene, thank you so much. And, NASHBIT and the team there has always been so helpful in helping us learn how to raise our voices and move the needle. And we really appreciate these templates that can really help us put our desires into something that could actually make some movement. So I hope we will be able to update you in a while about what we've done together as a group.
Me too.
So bring forward Dr. Goldman again. Happy to see you again in a different role. Talk to us a little bit about the Data Corner, which we look forward to every month. Looking forward to hearing what you've got to share today.
Great, thanks, Amy. I know last week's session was on TeenLink and teens participating in crisis services. And so I wanted to pick up on that thread and share some of the research that is very humbling and concerning regarding the youth mental health crisis in this country, and in particular, how it impacts emergency department boarding as a key issue, and then also considering how mobile crisis as a model has been studied to actually reveal potential impacts on things like emergency boarding and other outcomes. So just sharing a couple data, this is one of our, what we call our journal club feature within the Data Corner feature. From 2011 to 2020, pediatric mental health related visits to emergency departments increased almost twofold. So from 7.7% of all pediatric emergency visits, 4.8 million a year, to 7.5 million a year, 13% of all ED visits. So major uptick in emergency department use for mental health services among youth. Youth who are brought to EDs by police are more likely to be Black or Latinx, be on Medicaid, be in families without two parents, and have aggressive outbursts or suicidal behavior. So you'll notice some demographic and clinical trends there that reveal some concerns in terms of police interaction with kids ending up in the ED. And of course, the pandemic changed everything. So the graph that you see at the bottom here, that dark black line that you see dips in March or so, is the weekly psych emergency service encounters among youth in 2020. So you can see it just tanks right when the pandemic hits, and then it never quite recovered. So interestingly, there were fewer kids who are in the ED, and relatedly more mobile crisis services, but boarding in the ED, meaning kids who are staying in the ED for long periods of time, increased. higher rates of 30-day readmissions increased, and also admission to inpatient units decreased. So major issues with emergency department boarding. I'm not going to go into this slide in detail. This is just to share that there is a consensus panel that defined national pediatric best practices for kids who are boarding in emergency departments. So this is sort of a reference slide for you to circle back to. But on the next slide, I wanted to focus in my last minute or two on mobile crisis for youth. So this has been studied in a few different settings. One study in Connecticut found that mobile crisis has reduced emergency department among youth, although then there was another study in Iowa of both adults and youth receiving mobile crisis services that showed more emergency department utilization. A study in Los Angeles showed that over 90% of youth did receive some sort of outpatient services after a mobile crisis visit, but that then only 56.7% received more than one therapy session, and only 3% received inpatient care. So in terms of having mobile crisis see kids, a small minority are then going on to actual inpatient psychiatry. In New York, a study was done that found that multiple mobile crisis episodes happen in 22.2% of youth who received mobile crisis. So this is a reutilization measure, and that was more likely to be in youth who are non-Hispanic, had adjustment or conduct, mood, or suicidal thoughts and behaviors, and had more mental health care. Those had more mobile crisis utilization. But the main thing to highlight here, these are all single site studies. They're heterogeneous, meaning they're in different settings. Every setting is slightly different. And this really calls out, there's a review of youth crisis services recently that really highlighted there needs to be more studies replicated in other settings, especially generalizable settings, to really be able to draw on an evidence base to inform future practice to serve youth given the crisis that we're seeing. So the next slide is basically just a bibliography of a bunch of different studies related to youth and crisis services. So leaving this here for future reference for those who are interested, and happy to hand it back to Amy. Thanks for tuning in for Data Corner this month.
Thanks so much. And it's good to hear about the youth data, even though it's hard to hear. It's so important for us to keep our eye on it. And like we heard last week, the adult system just can't be retrofitted for this group. So appreciate the data that you're bringing forward and reminding us. Thanks a lot, Matt. All right. Happy to bring forward Stephanie Hepburn. Hi, Stephanie. Good to see you. Let's hear about your interview that you talked with Dr. Davidson.
So I spoke with Dr. Davidson. He is Dr. Larry Davidson. He helped broaden the concept of psychiatric rehabilitation when he was the clinical director at the Connecticut Mental Health Center, which is state funded, but it's run by Yale's Department of Psychiatry. And in a study, this was years ago, in a study conducted by the psych rehab program, researchers interviewed people in the aftermath of a state hospital downsize. And they were surprised to find that people felt lonelier in the community than they had in the state hospital. And that led them to the conclusion that reintegration requires support. So Dr. Davidson, he believes that people similarly need transitional support as they adjust to post-pandemic life. And he points to the peer movement on how best to do so. And I'll just leave it there as a teaser to go to the article to flesh out what that means.
You know, one of the things that strikes me, and reflecting back even to the boxing video we saw at the beginning, how important and how vulnerable we are at these transition points, and how important it is to, I mean, peers are one thing we can leverage, anything we can leverage to really help with those transitions, so that people can have some continuity of care, have it feel like care. And I've always been very impressed with the work that that Larry Davidson does. So it's interesting, his kind of parallel between letting go of the state hospitals and this period after COVID. I think you thought that was like kind of interesting, right?
I did. And I think with populations that were particularly detrimented by the pandemic or were already marginalized, there, you know, it seems like if you look at schools, students were very quickly and teachers very quickly thrust into that environment. And that's not the only environment. But I think we had this idea as a society, put people back in the environment that they were once in without any guidelines or assistance or help in how to do that. And if your support system dropped away during the pandemic, or you didn't have sufficient support at the onset, what do you have now to help you transition, and what can we do?
Yeah. I'll just say that I've been really impressed with the work that SAMHSA has been doing around school mental health and putting money and effort there. It's been so important to those of us who are parents, plus those of us who work in mental health, the recognition that they've gone through something and they weren't probably skilled to cope with it before, like, you know, their own mental health. And so even now it's so much more important. So again, always appreciate to hear what you're thinking about and your insights on some of these different topics. So thanks again for joining us today on the Jam. So David, calling you forward, talk to us about this amazing experience that you've been on before and that is coming up in 2024.
Hey, thanks so much, Amy. And really appreciate Steph leaning into, in her talk with Dr. Davidson, the impact of COVID. Dr. Goldman was talking about the changes with youth. One of the things that happened with COVID is we haven't had a global meeting or convening of the International Initiative for Mental Health Leadership since 2019, when it was actually in Washington, D.C., hosted by SAMHSA and NASBD, when we had countries from around the world come together. It was supposed to be in Christchurch, New Zealand in 2020. They did finally have a set of regional meetings this last year, but this is the first time that IMHL will be back together next June, the 27th and 28th in Utrecht in the Netherlands. Utrecht is actually just a short train ride from Amsterdam Airport. So this will be great. Steve Appleton announced this. He's the CEO of IMHL, which is funded in part through SAMHSA. And he announced this at the NASBD meeting over the weekend. So it'll be great to reconvene in Utrecht. Policymakers, researchers, providers, a lot of innovators, pioneers, thought leaders that will be joining together. If you've not been to IMHL before, the model is that there's a convening of everyone on Thursday and Friday. So let's back up. The Wednesday prior is a travel day. And Monday and Tuesday are a set of different opportunities spread out. The only really requirement is that they're an easy one-day travel to the main convening. So Amsterdam is going to be easy to get to, and there will be 30 or even 40 different match opportunities all over Europe. So think about matchmaking, like dating, like speed dating, but dating around specific topics. So my guess is there'll be a match on medication-assisted treatment and advanced substance use care. There will be something on justice, diversity, equity, and inclusion, women in leadership. So there'll be a host of different topics or disciplines or areas of commonality that behavioral health leaders have. Many years ago, Dr. Jerry Reed from the Suicide Prevention Resource Center and I first did a convening around zero suicide using this very match. The IMHL was in Manchester, and we did Zero Suicide 1 in Oxford. We went to Atlanta in 2015. We were in Sydney. We were in Rotterdam. And this coming June 24th and 25th, as part of that match sessions, we'll have Zero Suicide 5 in Liverpool. This was something that was planned, Amy, back for 2020 and is finally happening as part of the IMHL event. So we'll be partnering with Henry Ford Health System, with NHS Mersey Care, which is Joe Rafferty and team there in Liverpool. And I'm wearing my Liverpool Football Club shirt today. But we'll also be convening on the back end on Saturday and Sunday as a separate event altogether, the third global meeting for crisis care. So this is an opportunity for Crisis Jam in person. Dr. Brian Hepburn and I co-hosted the second global convening as part of that DC event in 2019. So 3 events, Amy, and we hope people will look at least for now, save the dates and hope you'll join us. But the main thing I wanted to share with this group is this opportunity to get together for the Rotterdam Crisis Summit number 3.
I have a feeling a lot of us would love to be there with you for this. It looks amazing, amazing to be with other people who think like us, and to focus on, as we talked about, stealing, heavily borrowing ideas from other people around the world that we can bring back and use in our own communities. So looking forward next week, Stefan Cortez is going to be here talking about opioids. That's going to be a great topic, something that a lot of us think about. And then the following week, the Bridge Center for Hope, Charlotte Claiborne is going to be here for episode 141. I wanted to thank everyone who was on this week, the Over Under, Rin Coing, Matthew Goldman for the hot seat and the data corner on youth, Adrienne Breidenstine and Chauna Brocht, who really talked to us about the transformation in Baltimore area, regional transformation, Belina Shaw, Shannon Scully, Carlos Makal, who gave us more insights into what's going on in Maryland, John Palmieri to introducing us to Jill Mays. Welcome, welcome, welcome. So happy to have you. Arlene Stevenson and telling us how to raise our voices, and Stephanie Hepburn on giving us more insights as she always does. Thank you, everybody, and we will see you next week. Bye-bye.